I also want to just touch on the health policy. So I guess we'll leave the polling behind for a little while. There was a question regarding, because you're from the Institute for Health Policy, there's a bit of conversation around COVID lockdowns, vaccine mandates, that kind of thing, testing.
Yeah.
I think you were very clear the last time you were on here about the need for testing, and I think you were very clear about your idea of lockdowns.
Yeah.
But I think it's important because the question's been asked, not related to the polling, but it's been asked. So what is your, and I think this is a good time retrospectively to ask you about Sri Lanka's COVID response. You said you looked at it as well, and it's something that you do.
Yeah.
Could you tell us, in terms of the international standards, how Sri Lanka has fared overall, and where you think we went wrong, where we should have done better? I think the testing part is something you've been very clear about.
So it's probably a good time to ask because we just published in one of the BMJ journals, British Medical Journal journals. We haven't publicized it, so we have to put out a press statement and put out some stuff. The findings from a very big study we did with Johns Hopkins University to look at Sri Lanka's COVID response. It was sort of retrospective, and we used some of this phone survey data as well. Right. So this is one of the few research items, academic items, which use this data. So what was now I'll tell you what we concluded, the kind of overall big findings there. So first of all, what we conclude in terms of the initial the initial response was good, partly by accident, and then the subsequent response was a failure. In fact, as I said even at the time, probably the worst public health failure in this country for half a century, right? So let me start off with the first year. 2020 was unusual, and we show this in the paper. It was unusual because, and I'll give you a kind of little data snippet here. Sri Lanka was one of the probably 20 countries in the world where life expectancy increased in 2020. Yeah, people think, the pandemic health is getting worse and people have lockdowns, they can't go to the hospitals. Most of the world, life expectancy dropped. It was a huge impact. We've never seen anything like this since Spanish influenza, right, for 100 years. But there were a few countries, 20-odd countries, where it actually went up. We were one of them. So government's own official data on mortality, not COVID mortality, overall mortality, shows a drop in mortality. And why were we in that bunch of 20 countries? Those 20 countries were the zero COVID countries, so called those days, right? These countries like Australia, New Zealand, Vietnam, Cambodia, Bhutan, so Taiwan, not a country technically. And then, Japan and Korea also did.
These are countries with extreme lockdowns.
No.
These are the opposite. These are the ones that said open up completely.
They had, pretty much everyone had lockdowns at some point. But the secret in that first year of these zero COVID countries was they basically did all the same three things. And we initially did the same three things. They secured the borders. We did that effectively. And we say in the study, and I have to say, I would commend maybe it's sometimes unpopular in some areas of civil society. I mean, we benefited from the contribution of the military, who handled the quarantine system, and we should be grateful for that. We were able to minimize, not completely stop, but minimize entry of the virus for about 12 months. So that was great. That's what all these other countries did. Seal the borders. The second thing they did was they said, look, we're going to still get infections and we're not completely stopping people landing, right? We can't stop. So like it's not North Korea where they can completely seal the border. We still have planes and ships landing. They go to quarantine. Even with a good quarantine system, infections are still going to get in. So when that happens and we find cases, we have to do contact tracing and isolation immediately of close contacts to prevent it going further. That we did really well. So we cite some data. This reflects the strength of our public health system. A typical contact in 2020, a typical case when they did contact tracing, we would find 20 close contacts, 25 close contacts, and they were all put into isolation. UK, they could only find 4 or 5. I mean, the UK was terrible, right? But we did really well, like Australia, like New Zealand. So we got that bit right. The third bit was where we got it wrong, and it eventually caused the strategy to fail. And that's what I have to say. I mean, it's a feeling of saying I told you so, but unfortunately it's correct. What we got wrong, what these other countries did better than us, was they understood you had to have symptomatic testing of coughs and colds at primary care level in the community. Not random testing, which is what we often did. Not testing of better off people if they could afford private testing, which is what we did sometimes. Not, oh, we'll test everyone in some community because we're going to put them on a lockdown, which is also what we did. And not testing of people in hospital when they're so sick that they have to be admitted, which is what we often did. Testing of coughs and colds and fevers. We never did that. And I may have mentioned this before, but the research behind that approach comes from a Sri Lankan Australian researcher. We did not know. And we did interviews as part of this study of senior politicians, civil servants, people in the medical community, people in the military. And what we heard was two things. We heard from the political level, if the Ministry of Health had told us this, we would have given the resources. And we know they had the resources. World Bank gave us money, which was in the end not spent. We had money for testing. We even turned down testing machines. There's a big scandal, right? In the middle of 2020, the Ministry of Health turned down testing machines, right? And then when the Randix outbreak happened, they didn't have the capacity. And the military also told us. We heard from the military, people blame the military for handling this. The public health decisions were based on what the Ministry of Health, public health people said, and they did not tell or understand themselves the critical importance of testing like this. And so the thing failed. And what that modeling by that Sri Lankan Australian did back in early 2020, it basically said, if you don't test enough, you'll get hidden chains of transmission. They will last for weeks and months, and then when they appear, they're too big to control. And so they said, her strategy, that researcher, the colleague's strategy was, in Australia, we need to have sufficient testing so we catch these outbreaks. They're going to happen, but we want to catch them when there's still about 20, 30 people in the community, because at that size, we can probably have a good chance of squashing it. The Brandix outbreak, we now know. We know from two different sources. So one is from the CJR researchers. They did the genetic analysis of the outbreak from the Brandix virus. Clearly indicates the virus probably came in around June. If you do standard epidemiological analysis, it also points to an entry around June. So from June to September, we had a hidden transmission chain infecting hundreds of Sri Lankans, not being picked up because we weren't doing this community test. So that's why the strategy failed. So strategy failed after 1 year, then controls are lifted, and then want to let tourists in. They never really were able to raise testing enough. I think the Ministry of Health senior officials gave up trying to control it. It was more like a mitigation, this kind of thing. And then we had Alpha and then Delta. And what you see in 2021 and 22, and this is now official government of Sri Lanka data, right? We're not making this up. Huge spike in mortality. So I'm not looking at COVID deaths. COVID deaths are only 14,000. If you look at the overall deaths in Sri Lanka from 2020 to 22, that's those 3 years, there is an excess 40,000 deaths. And this is despite the fact the death rate went down in 2020. Those other zero COVID countries managed to keep the death rate low all the way through to the end of, say, 21. Eventually, they all gave up trying to control, and they all eventually opened their borders. But at that point, they were vaccinating people, and they could prevent deaths. What happened in our case was the virus came in before that in a big way. And so I think that the death toll of the pandemic for Sri Lanka is probably not the 14 or whatever thousand the Ministry of Health reports official data. It's certainly based on the government's own official data. We're talking about almost 40,000. And we had a huge increase in mortality, and we would have had a huge drop in life expectancy. So then our mortality pattern went from being like Australia's to being like the UK and the United States. And what we now see in very recent data, actually I have not seen discussed in the media, and maybe I should write something about it, in the most recent estimates of mortality from the statistics department, they've given estimates up to mid-23. And we have continuing excess mortality, higher mortality than we should expect, continuing into 23. That I don't think is just COVID. I think it's economic crisis. But in 23, the population shrank. This is the official government statistics. I've not seen any comment about this. Sri Lanka's population shrank. And according to the statistics department, and the reason for that, one of the reasons is that this increased mortality. So these are serious things. So I think what our kind of take on the responses, we did initially without realizing why, public health failure to understand the role of testing, then the control strategy collapsed. But on other positive sides, quarantine worked pretty well, border security worked pretty well, the vaccination program worked really well. But there is one weakness, there were two weaknesses. We didn't really go for vaccinating kids. We should be vaccinating kids right down to 5 years or 3 years. And we the messaging was terrible in general. And so we never got high uptake of the booster. So in fact, right now, what I would tell everyone who's listening, I would say as a public health physician, COVID is going to be with us for pretty much for a long time now until we figure out a solution. You should probably get a booster every year, every 6 months. I happen to travel frequently, so I've had 4-5 boosters, okay. Right? And so I do that on a regular basis. But that's what it's not a possibility for Sri Lankan. Right. Government isn't buying those vaccines. But if you had, that's what you should ask your politicians to provide that. But yeah, I think the vaccination was okay, but it has some limits. The other thing was testing. Vaccination was monopolized by the state. A lot of, which I think was correct. Testing was opened up to the private sector, but what happened with testing, it became very unequal. So our analysis shows vaccination, no income inequalities, no real ethnic inequalities. There was some delay with the Muslim community, but that was it. But it's pretty much equal. Everyone got vaccinated. For testing, a very big rich-poor difference in access to testing. And that was because we chose to go with this, okay, let's bring the private sector in. And, testing at that point, it's a preventive public health strategy. That's like the kind of thing you should put into, depend on private.
You mentioned the excess mortality.
Yeah.
Did Sri Lanka have higher excess mortality than some other countries that you noted at the time, at least in that period?
So what we show, there's a chart in our paper. We compare ourselves to the zero COVID countries. So in 2020, our mortality fell dramatically. That was a real offense. That's why I know life expectancy went up, and all those other countries went down as well. And we had a similar reduction in deaths in 2020 to Vietnam, Australia, New Zealand, etc., Cambodia, Bhutan. But then you see in 21, those countries sort of maintained it. Ours shot up again. And it went above the typical level to above the typical average level. We had extra deaths. And we went up to the levels of the US and UK. So that was 21, 22. Those countries, eventually, the death rate started to go up as they let COVID, the virus in, but they were vaccinated. But they never had this huge increase in mortality. We went from Australia and New Zealand outcomes to US, UK outcomes. I think the previous president of the US and the UK were the models, so maybe that's what he wanted. Because I noticed that in the vaccination study, that was the model. So we got what we wanted, or we got what the president wanted. Wasn't so good for 40,000 Sri Lankans.
You just mentioned about boosters vaccinating children. Yep. There was a report recently, I think you discussed this, but I just want to touch on it because we have a bit of time.
Yep.
Regarding the new study on COVID vaccines.
Yeah.
And these links to very rare conditions. And it sort of created a consternation amongst the population about the safety of these vaccines, whether this was something we should have done. And you've just said that you should get your kids vaccinated. And I know that I'm expecting, my wife's expecting, so it has to be a father soon. So it's an interesting question that when I was getting the vaccine, I didn't think twice about it. I'll take it. I'll take it again if health policy dictates that. If it's a child, there's always a little bit of extra question. Is this safe for my child?
Sure.
Should I take it? And also, we've been told that younger people, generally have better immunity. They can generally take the COVID infection better. Is it really important? And then you have the conversation about herd immunity as well, whether that's something that children can get herd immunity instead of getting the vaccine. So I want to just unpack a few of those things there. I mean, I know it's
sure.
a lot, but if you could just go on giving us a rough idea on your point of view and the data that you used to back
on the study and the general issues around it.
Yeah.
So let me just remind you, back in 21, we, as in the rest of the world, as WHO, the regulatory authorities, the public health authorities, approved COVID vaccines on an emergency basis for giving out, and countries, governments, in most cases, pushed everyone to get them, at least all adults. Now, this was not based on the normal assessment of safety. All vaccines have, like any medicines, like all medicines, even paracetamol. If you take enough paracetamol, you're taught this in medical school, you can die. Not that many, actually. You die of liver failure. I won't say what that number is here on this. We don't have a good thing to say. We all know that. So all medicines, all vaccines have potential side effects. Vaccines are no different. Vaccines generally are safe, but when they were authorized on an emergency basis in 2021, it was done because millions of people were dying, and the judgment, which I think was correct, was even though we didn't fully understand the risks, it was clear that whatever those risks were, they weren't at such a high level that it overrode the fundamental, I would say, public population need to get people vaccinated to slow down the virus and also to protect people. So I think that's the emergency case, and that was correct. It remains correct today. Now, this study is about very rare side effects. Okay, now, I was asked about this by another journalist, and I said, this is really much ado about nothing. When I read I think it's in the Daily Mirror, actually, it's not your newspaper, right, or you work for. I saw this report about these comments from the medical community, and I didn't pay much attention. I thought it was, it's kind of strange, but I'm not going to waste my time. And then I was asked by one of your colleagues to about this. I investigated. I think this is more a reflection almost of illiteracy by many of our medical professionals. Probably one of the reasons we did badly in 2021 in the COVID response. Right. So let me explain what that study was about. So I think it's a study in the journal Vaccine. It has good people did it. It's a WHO-supported research network. The significance of that study was that this is the largest study done with good quality data to estimate or look for side effects. And they were looking particularly for cardiovascular and neurological side effects and muscular. Young people might get that. And they did it in, I think, 10 million people. 10 million people from 8 countries around the world had access to very good data. And they were able to quantify, they looked for problems, and then if they found a problem, they quantified to say, what percent of people getting the vaccine would get this problem. They got very accurate estimates. So that's the significance of the study, right? I mean, it's a good study and welcome. But is it a news story outside the scientific community? It shouldn't be. Basically, what their findings on the size or the frequency of the side effects were consistent with what we already knew. In fact, some of the side effects were listed in the WHO emergency authorization. They even picked it up in the initial clinical trial. So things like this were known. What they did was they just put better numbers. There was only one small side effect, I think, which was newish. It had been suggested, but nobody had quite really kind of fingered it properly. And that one, with their huge 10 million sample, they found, I think it was like 10 cases. 1 in a million, right? They said, this illness that they detected, I think they said, only 2 people should have got it because it happens for other reasons. And they picked up 10. And so, yes, this is statistically significant, but 10 out of 10 million. And that was the only new finding. Now think about it. We're saying 2 versus 10, so 8 extra people or 7 extra people got it, and we vaccinated 20 million people in Sri Lanka. Well, 14 people will get it. This is not something to, this is not, sky is not falling down. I have no idea what some of my medical colleagues were thinking. Probably they didn't read the paper, or maybe they don't understand numbers properly. And so it's nothing to get excited. It's a non-story. The real story here, as I said, it's how the medical community reacted to it. That's more of an interesting story for me.